Hi everybody, we will get started shortly. Please make sure that you can hear the music and the audio right now. Hi everyone, thank you for joining us at We Got This WA webinar series. I'm Sarah Childs, I'm the Executive Director at the Business Health Trust and am so excited to be able to moderate this discussion with Kaiser Permanente. We will be doing this webinar series with the Seattle Metropolitan Chamber of Commerce and Business Health Trust, really with the focus of getting our members to hear directly from experts. We have focused on unemployment, federal lobbying around COVID-19 stimulus bills, and now looking at the medical side and the medical lens of COVID and hearing directly from experts here right in our area. I wanted to take a minute to thank our sponsor and event partners. Advanced Professional Insurance Services is our sponsor who has made all of this possible to allow all of these webinar series to be free of charge. We will also be making the webinar available afterwards, and they will be posted on the Seattle Metro Chamber event page later today. Few webinar logistics. If you need technical help during the webinar, please use the chat box. If you have a question for our speakers, please use the question and answer box. We will do our best to get to question and answers at the end. However, it will be time dependent and based on kind of how the presentation progresses. Well, with that, I wanted to introduce our speakers today, Dr. Deb Friesen and Todd Hess from Kaiser Permanente. I will turn it over to you, Todd.
Thank you so much, Sari, and thank you to the Seattle Chamber and BHT for this opportunity, really to share some important information. What we want to do, what Dr. Friesen and I would like to do today is really to share information around what the coronavirus is and the science around transmission as it's currently understood. Coronavirus and how they spread, what we're experiencing and seeing in the community, and then how Kaiser Permanente Washington is responding, and how you, the workforce and employers, can help slow the spread. I'd like to now introduce Dr. Deb Friesen.
Thank you, and I want to make sure that everybody can see my screen. Can you see the presentation up there?
Yes,
we can. Deb.
Okay. So no matter what you do, once you start, you have some technical difficulties that start in. So let me get myself arranged a little bit here, if I may. Just one moment. And what happened is I lost my my alternate presentation here. So just one second. We are good to go, except now you're seeing, are you seeing my screen now?
We are, we're seeing two screens, two slides.
This is crazy, okay. Let me try again, and we're gonna start at the beginning. So my apologies, everybody. And Well, what do you know? I do apologize. All right, I think if I can now just get myself started again, we should be okay. And let me swap it out, and I'm good to go. So I am Deb Friesen. I am an internal medicine physician with Kaiser Permanente and physician advisor. And it is really my honor and my pleasure to be with you here today. So very much appreciate having your time. What we're going to cover is a little bit about coronavirus itself, control measures around that, what Kaiser Permanente has done to respond to the challenges of dealing with this, and then lastly, what you can do to help in this area as well. So it's really amazing and frightening how quickly this has spread and evolved over the last few months. Take a look at that timeline. On the left-hand side is December 31st. And this is the date that the World Health Organization was first alerted about coronavirus itself. You can see the next is January 13, is the first case outside of China in Thailand. And then in January 21, we see the first case in the United States. We are now at March 31. So just over 2 months, 2.5 months, and look at how much things have changed since then. March 11, the WHO declared COVID-19 to be a pandemic, which is the worldwide spread of a new virus. You can see those numbers as of March 11, 118,000 cases. And now what we have is 163,000 cases in the United States. 2,800 deaths. In Washington, there are almost 5,000 confirmed cases, 4,896, 195 deaths. So this has just literally done what pandemics do, which is spread incredibly rapidly. And a lot of it has to do with the virus itself. So this is called coronavirus, and I want to tell you a little bit about that. So coronaviruses, because when they were first able to be seen, they actually looked like they had, it was a crown around this ball. So that's how it got corona. And it was first diagnosed or seen in the 1960s and known to be associated with human disease back then. You may have already had a coronavirus in the form of an upper respiratory tract infection. Even now, they're responsible for about 10 to 30% of those infections. There are 4 types of coronaviruses. The alpha and beta have genes that come from bats and rodents, and they're associated with human infections. And then there's delta and gamma, which come from birds and do not infect humans. There are 2 beta viruses that cause serious infection. You may remember SARS, or severe acute respiratory syndrome in China, and MERS, which is the Middle Eastern respiratory syndrome in Saudi Arabia. So viruses can change, they infect animals, they can evolve and then make people sick. And then we get a new human coronavirus, and we think that's what has happened here. The name of this virus is actually SARS-CoV-2, and the name of the disease that it causes is COVID-19. So in front of you, got an artist rendition of SARS-CoV-2, and there's 4 main structural proteins, 3 of which are on the surface, and I've pointed out here because they're going to come up a little bit later again. There's the E in yellow, that stands for envelope protein. M is membrane protein in orange, and S, or the spike protein. Now, the structure of the virus also provides some clues about its success. You can see there, it's essentially a spiky ball. And these spikes recognize and stick to a protein that's on us, on our cells. It's called ACE2. And that's the first step of an infection, when it sticks. And those contours on the virus allow it to stick far more strongly to that ACE2 receptor. And so in general terms, the tighter the bond, the less virus that's required to start the infection. Most viruses tend to infect either the upper or lower airways. So you either get that upper respiratory tract infection, which gives you the really snotty nose and sore throat, but it tends to be milder, or a lower infection, which is that deep cough. It's harder to transmit, but it's more severe. And bad news is SARS-CoV-2 seems to infect both the upper and the lower airways. So how is it transmitted? This is an evolving topic of conversation, but what we think is that it spreads person to person via respiratory. This is when we cough or sneeze or even when we talk. Those droplets can then land in the mouth or nose of people within 6 feet. They can also be inhaled into the lungs. Symptoms usually occur 4 to 5 days, but the range is anywhere from 2 to 14. And it's that 14 days, which is where the self-quarantine number comes from. People are most contagious when they're when they have the most symptoms of the disease. Unfortunately, we've also found that people can spread the disease when they don't even know that they have it, which is what we call the pre-symptomatic period. You can also get it from contaminated surfaces and objects, but it doesn't seem to be the way that this virus is transmitted for the most part. So I'm going to teach you some epidemiology here, and the R0 is what we call the reproductive number, and it's the number that people in public health look at to understand how this is being spread. And what it is if you have a completely susceptible population, which is what we have, and one infected person, how many people do they spread it to? And so you can see for measles, which is airborne, it goes to 18 people. COVID-19, because it's droplet, is 2 to 2.5. So not as many people as measles, but certainly more than the flu.
So doctor, I have just a quick question. You know, one of the things we're wanting to do is also to dispel myths during this COVID-19 pandemic. And we have a question from someone that they've heard recent evidence that suggests the virus may be airborne. Is that possible? Could you talk a little bit around that?
Yes, so it is completely possible. And we are waiting for guidance from the CDC to give us more information about that. But again, it looks like the majority of the cases are respiratory droplet, and that it is possible that there could be some airborne component to this. We saw a choir where there were asymptomatic people show up. No one was coughing. No one reported to be sick. They actually avoided personal contact, like hugging, like choirs do. They didn't stand as close together, but they also weren't 6 feet apart. And I think that something like 75% of that choir ended up testing positive for COVID. So there's still a lot that we have to learn around this disease.
Thank you. That's really helpful.
You're welcome. Clinical findings, you all probably have heard this over and over, but again, we're really looking at fever, cough, shortness of breath as the main things that it presents with. One thing that probably ought to be added to that slide is loss of smell and taste. This started out as just kind of a, isn't that interesting? But we're seeing it more and more. One of the things is that even though we're highly infectious, 80% of the time, it's mild to moderate still, 20% severe and critical. And partly that's because of, again, the way that virus itself works in that susceptible population. And we're going to talk about that in just a little bit more. Once it attacks those ACE cells, those cells will then actually slough away, and they will sometimes carry the virus even further downward into the lungs. And so that's partly the reason that people are having so many respiratory problems. The lungs actually get clogged up with dead cells and fluid. The other part is the virus seems to really stimulate the immune system in some people. Now, for most of us, a vigorous immune system is a really good thing because that's how we fight back and attack that virus. It's what causes us to kind of feel awful with inflammation and causes fever. In some cases, the immune system will actually kind of go berserk, and it then does a lot more damage than the virus itself. One of the ways that we fight is to bring those immunologic components into the place where the virus is. And so our blood vessels will get just a little bit leaky to allow those things to kind of seep through to go to the right place. But sometimes the vessels become too leaky and the lungs fill up with even more fluid. So we are seeing those critical cases with things like sepsis or widespread infection, acute respiratory distress syndrome, multi-organ failure, just awful illnesses that can arise from it.
So another clarifying question, could you talk about the difference between mild and moderate symptoms to severe symptoms? Like what are some of those differences and how people might know if they have moderate or severe symptoms?
So one of the ways that I tell my patients to think about that is, if you're not sure, would you please pick up the phone and let us sort that out with you? Everybody should have a thermometer at home and be checking their temperature. If it's going over 100, I'm going to start worrying about you. If your cough turns into something that's more continuous and you feel a little short of breath, you're really moving from mild to the moderate place there. And then vital signs, which not everybody can do at home, but if your pulse is rising, if your temperature is high, if your oxygen is coming down, then we're really moving again into that moderate, even into the severe category. Might not need to go to the hospital yet, but you really want someone with medical knowledge to go triage. So please, when in doubt, give us a call. We will work through this with you. The other piece is the underlying things that people have, and I'm going to talk about that in a moment. So a really healthy person who just has a temperature and feels a little bit achy, I'm not going to worry about so much. But if you have a temperature and you're achy and you're a diabetic with heart disease, that's also just a different category. So there's a lot of nuance to that. I wish I had something a little bit more definitive to share with you, but you kind of know, and I just want people to trust themselves here. If you're feeling like this isn't just mild and it's moving into moderate, please give us a call. We really want to help work that through with you.
Thanks.
I just want to demonstrate the power here of social distancing and what a difference it makes. So we talked about the on top, that one person infects 2.5 people in 5 days. Now, those 2.5 people will go infect another 2.5 people, another 2.5 people, etc., so that at the end of 30 days, we have 406 people infected. And if all you do is reduce your interactions by 50%, you go out half the time as much as you usually did. And so you're only at 1.5. At 30 days, it's 15. It's remarkable. And again, 75%, only 2.5 people are going to be affected. So social distancing, physical distancing really does make a huge difference here. Other things can present looking like COVID-19, which is a problem right now because we're still seeing the flu. We're seeing a lot of other things. I said that coronavirus, a different kind, can actually show up. So all those upper respiratory and lower respiratory things can still be happening at the same time. So it makes it tricky when we don't have testing available. So let's talk about testing and the test, and then we'll go into the test and who gets it. So we talked about how it first showed up about December 31st. The full genome was published January 10, less than 2 weeks later. This is just phenomenal that we were able to understand this virus to that degree in less than 2 weeks' time. And because we knew that, we were able to look at the virus particles itself and start developing what are called a Pcr test. And the first test that was done was that E gene. The E gene is the one that makes the envelope protein that I showed you earlier. And then after that, the CDC also worked on detecting the N gene. And there's actually a whole bunch of testing going on right now. And you can see that other Roche test on the bottom, less than 4 hours. So as these become available, we're going to see a lot different numbers come up. The CDC is also working on developing 2 blood tests, serologic tests, and those are going to be looking for previous infection and looking at antibodies to the coronavirus. And that's going to be really important because what we can then do is start looking at populations and who's already had and who's now immune so that they can go to work and know that they're not going to be spreading it. They've already had it. They were part of that 80% that had a mild case that maybe didn't even know that they had it at all. So this is really going to help us to do that. The FDA is working with over 230 test developers who are or are expected to submit requests for emergency authorization. So we'll see a huge increase in testing, which will also give us a huge increase in the caseload, right? Once we are able to more accurately understand what that's about. I alluded to this earlier. The older you are, the more at risk you are from dying as a complication of the coronavirus COVID-19 infection, and made worse if you have other things that go along with it, such as heart disease, diabetes, chronic respiratory disease such as emphysema, COPD, even high blood pressure and cancer. And so really having to pay attention to our patients who have these conditions in order to keep them safe and healthy.
So doctor, I have a couple questions as we're talking about the testing, specifically around the serum test, as we get more information around people who have had it and what sort of immunity they might have. Is there any research done yet on if people can get reinfected?
We have no idea right now. Dr. Anthony Fauci, who is kind of America's doctor, he's an amazing virologist. I heard him speak when I was in medical school about HIV, and he has said that there is no reason not to believe that once we're infected and have antibodies, that won't be providing some protection. And so to the extent that we will have that, how long we will have that, all of those remain to be seen. It's just too soon to tell.
Yeah, it's certainly an ever-evolving process right now.
Yes, yes. And was there another question, or were those kind of the same too?
Same too. Another question is around the pre-existing conditions, high risk. So talk to us about if controlled hypertension would be something that would consider someone high risk also for this.
So again, the answer is yes. And it was kind of interesting. So I told you that those are called ACE receptors that we have on us. And one of the medicines that we use to treat hypertension is an ACE inhibitor. And so early on, people were really curious as to whether there was a connection between that medication and hypertension and increased risk for fatality. There was no connection at all. And back to your original question, controlled conditions seem to be associated with a better mortality, but again, we don't have hard and fast data on what that looks like right now. But in general, we know for general health that if you have diabetes, but it's under really well control, that you're going to do better than someone who's out of control. And so extrapolating from what we already know, that would be true in this case as well.
Thank you.
You're welcome. What about treatment? There is no specific antiviral treatment that's recommended. We just don't have anything available at this time. And so really for the most part, it's supportive treatment. So just like when people get the flu, it's focusing on prevention, monitoring, and doing what you do to just rest up and take care of yourself at home, partly so you don't spread it to other people at the same time. When people do need more care, so when they've gone to that severe or critical and they need to be admitted to the hospital, it's around oxygen, IV fluids, keeping their fever down, supportive care for all those things, including ventilation and intubation. We know from our experience from MERS, I mentioned earlier, that steroids aren't helpful. I talked about that immune response, and what if we could suppress that? So we know that steroids can suppress the immune response. Is that helpful? We know from other conditions like MERS, it really isn't. It actually increased mortality and it decreased the viral clearance, which means that people were kind of shedding the virus for a lot longer as well. We are studying medications, of course. You've heard of chloroquine or hydroxychloroquine in the news. It looks the most promising, and I believe there's, it could be that we are right on the cusp of an approval for treatment. It's been used for years for malaria. We also use it for autoimmune disease. It might also be helpful for exposure and preventing people from getting it if they've been exposed. There's other drugs on here that have been used, Ebola drugs, HIV medications, other antivirals. The reality is, right now, we just don't know. We're trying to do it in a scientific way. We're trying to do clinical trials so that we know if they're effective or not. What we do know is people are starting to hoard these medicines, making it harder for the people who are known to benefit from them, a little bit harder to get a hold of them. And that's always hard to see. What about a vaccine? Vaccination is a very big topic. There are currently 35 companies involved in clinical trials. Of interest, one of them has begun phase 1 clinical trials, and just last week in partnership with KP Washington Health Research Institute. This is a phase 1 trial, and it looks at healthy people to make sure that the vaccine is safe and to look for any side effects associated with it. Phase 2 will come later, and that'll be in areas where they don't have as much of the virus to see if it is effective. But no matter what we do, it looks like it will not be available for widespread use for at least 12 months.
So it sounds like a vaccine is, 12 to 18 months out. You mentioned on the last slide some of the medicines that are awaiting approval for treating folks that are infected. Do you have any sort of estimation of a timeline that you think might be realistic around kind of that approval for treatment?
I just don't. And partly it depends on what actually in our studies shows to be effective early on,
Right.
and how effective it is, right? So if we try a medication, and again, we have to randomize and control to know we have a comparison between two groups. And if we have an intervention with a medication and group 1 kind of does as expected and they don't do well, and group 2 does phenomenally, well, then all of a sudden we've identified something. But we have to have a lot of trials going on at the same time with a lot of different things so that we can maybe see what is going to be a really fast horse out of the gate in order to hit something early. And if we don't hit something early, then we just keep doing more trials until we get to that thing. It's so hard to tell right now.
Great.
So let's talk about what we can do to protect ourselves and to protect others. So things that we should be doing all the time, knowing how it spreads, again, respiratory droplets, maybe airborne, and keeping that social distance. Clean your hands often. So one of the few mercies is that coronaviruses are easily destroyed. So each virus particle has on the inside a small set of genes or DNA, and then wrapping around that is fatty lipid molecules. And these lipid shells are easily torn apart by soap. So just 20 seconds of thorough hand washing can take down that virus. We've also seen that the shells are vulnerable to the elements. There was a recent study that showed that the coronavirus SARS-CoV-2 survives for no more than a day on cardboard and about 2 to 3 days on steel and plastic. They just don't endure in the world. They really seem to need bodies in order to multiply and spread. Avoid close contact. You know about the 6-foot rule. And again, it really matters if we do this. We're seeing that over and over in the media. Stay home if you're sick. This is probably the most important one. If you have any idea, please stay home. Cover your cough and sneezes. The internet is full of memes right now that you can actually see what happens if you cover with your hand, if you cover with a Kleenex, if you wear a mask. All of those things are super important. Wear a face mask if you are sick so that you don't infect others, and of course, clean and disinfect the environment.
So you mentioned wearing a face mask if sick. As we're still learning about the airborne nature or not of this virus, at what point do you think that it's prudent for people to be wearing masks or not, going to grocery stores and those sorts of things if they're not symptomatic?
I think it's prudent right now. Quite frankly, we're waiting for the CDC to give us an official recommendation on this. But really, other than potentially using up resources that healthcare professionals need in order to give care to those who are most sick, there is no harm in wearing a mask. You can make a mask out of a bandana. It's kind of like hand washing. You know, just because we don't all do it perfectly and do the 20 seconds and get all of our crevices, should we stop hand washing? I don't think so. And so if you are going to go out in the world, it might protect you and it might protect others from you to wear a face mask. So we've moved from containment to mitigation, but we're still using containment strategies. And again, isolation if you're sick. It's just so important that people are isolated. And this means that all the people in your household also need to be isolated at home, unless you actually have a way to live in a different room if you're sick. But if you're sick, your household is considered to be, again, something that can even be spreading that disease asymptomatically. So if someone is sick and goes to visit a neighbor who also has people who go visit someone else, all of a sudden there's a big long chain that's still in effect, and you have to break the chain by not seeing other people. Self-quarantine is if you're exposed. So for known exposure people, they actually need to stay home for 14 days, no visitors if possible, again, even isolating themselves in a separate room altogether. And of course, the goal for all of this, you guys know this new phrase, right? Flatten the curve. The goal is to space out the infections over time so that we don't all get sick at the same time, which is the danger of overwhelming our healthcare system right now. We want to look like that blue curve and not the red curve there. And again, the best way to slow down transmission is social distancing. Employers can help out as well by encouraging people to work from home whenever possible. And then the last one is shelter in place. And that's only for those folks who are supposed to leave, who are essential activities. So health or safety, seeing a doctor, getting food or getting pet food even. In most cases, people can still exercise, but going out to a park and kicking a soccer ball, or a lot of people congregating, is still not really what's considered around shelter in place. It doesn't apply to people working in healthcare, government functions, grocery stores, pharmacies, etc. I'm going to transition over to Kaiser Permanente Washington's response and strategy and what we're doing to support our members and really reduce that community spread as well. Again, we're really working so hard to care for our members, our patients, ourselves, and our community. We really do have the people and the facilities that are needed to deal with this kind of crisis. KP Washington has almost 1,500 primary care doctors and specialists in our physician group practice, almost 10,000 employees, numbers that have really grown over the last 5 years, reflecting the growing number of members that receive care at our facilities. We not only have the people and the places, we have the know-how. We have been doing disaster planning at Kaiser Permanente for years. We, of course, this is our mission to take people. We've been through pandemics before. If you remember the H1N1 pandemic of 2009, every year we run our influenza campaign, wanting to protect our members from even getting the flu, but also taking care of those who become seriously ill from the flu. We've been convening task forces, command centers at all levels. And even with our large number of physicians and employees, we have rapid ways of training them and educating them as needed. Because operations are quite standard, because we work very similarly from medical office to medical office, we're really able to roll out new recommendations and protocols. So how does this translate into care of our members? So one of the ways that we've done that, something that we've been doing for years. We're very fortunate that we've been spending a lot of time investing in telehealth. And even before the pandemic, we have been offering telephone visits, video visits, even e-visits around primary care and specialties. And all of these have been done and will continue to be done without any cost sharing on behalf of the member. The goal, of course, is to keep people out of the clinic setting as much as possible. So we have really ramped up and increased our availability of telehealth visits, helping to keep people safe, addressing what we can. When I was in med school, there was a saying that the history is 90% of diagnosis. And that has never been more true in proving that axiom than right now, because we really can learn so much without having to lay a stethoscope on people. And when we are able to do this, again, everything is connected through our electronic medical record. The chart's there, so I can see what their problem lists are, what their medications are, what they were in for recently, and I can document everything as well. So people have been very, very appreciative that they've been able to reach us through our electronic means. And then the other thing that we've done is convert a lot of in-person appointments over to telehealth at the same way.
So Doctor, I will give a very shameless plug for all of the telehealth efforts that you guys are doing, and just across so many medical carriers right now. So everyone on the call, if you have not had the opportunity to enroll yourself in the telehealth system, it is so much easier to get care when you are already signed up and familiar with it. It's such a convenient way all the time, but particularly right now, to get that medical guidance if you have questions about symptoms or just questions or concerns about something not COVID related, so that you can continue to get treatment.
Absolutely, and thank you for that. And signing up is easy. It's on kp.org. It's actually about a 2-minute process. And then once you're there, it's a pretty intuitive website and email process, or go on and get a telehealth appointment set up. So thank you for that plug. Appreciate that. So other things that we're doing is really responding to the community concerns. We're listening to the recommendations by the American College of Surgeons, and we have reviewed all of the scheduled surgeries and procedures, and we are postponing them so that we can be confident that the health of our members and staff won't be compromised by further spread of the coronavirus. Now, there are some things that we can't postpone, and we are still taking care of them, but if they are non-urgent, if they're elective, if we're able to, we are postponing them. That allows our members to be safe. The other thing it allows us to do is to look at our facilities and our people in them, so that we can make some decisions about where they can do the most good for the most people. You can see in that second bullet that some KP medical facilities and all care clinic at Bartell drug locations have temporarily discontinued in-person care. And the goal again is removing that potential exposure so that when people do have to come in, we're prepared, we're keeping them safe. It's easier to do with less facilities right now, and we can also deploy people to the facilities where they are needed. Which is what I just talked about, increased staffing and flexible deployment. So let's transition into what we can do around COVID-19 testing. So believe me when I tell you that we are as frustrated as the rest of the country at the difficulty in obtaining the tests and the supplies to do them. We started, like everybody else, testing through the public health department. And as soon as it was possible, we quickly expanded into other FDA-approved laboratories. And there's still not enough capacity with what we have there. So there's ongoing shortage of swabs and testing media. And so we've had to make the decision that we're going to limit the number of tests that we do to those who are sick enough where the results actually change our treatment plan for them. And usually that's people who are, again, in that moderate going over into the severe and critical. When we do a test in medicine, we really should be thinking about how is this going to change our advice or our treatment. And so for those people who have mild symptoms, it's not going to change anything for them. We're going to talk about the symptoms to watch for. We're going to do follow-up appointments to make sure that people aren't getting worse. But because there is no specific intervention that we can do, the testing in that category actually doesn't change anything for them. So for milder symptoms, asymptomatic patients, we are not currently doing testing. We're saving it for those who really, it would change the course of their illness to know if they're infected or not. So only available for high-risk patients who meet specific criteria. There isn't cost sharing for the screening or the testing. And again, we are using public health and FDA authorized laboratories. The biggest thing on this slide is really, please contact us before coming in. Testing is by appointment only, and we need to direct them to the appropriate place. And so don't just drive in, think you can walk in and get a test done. Again, you've got to meet criteria, and it's happening where we want you to go for that. Want to let you know that we have had some changes in our time, how we need to sometimes redeploy and keep people safe. And so you can see as of today, there are open for urgent care, all of these facilities that you can see on the left, medical offices that are available for face-to-face visits. We know that people still have needs that are not COVID related, and we want to take care of them. And then potential drive-up testing stations for potential COVID. And again, these are only by appointment. What about pharmacy? We know that people are going to be stuck in their homes for a long time, and we want to make sure that they have enough of their regular medications to last them. When we can, we are really encouraging people to switch over to mail order, especially for their chronic medications. You can see, again, prescriptions are delivered via mail order with no shipping costs, and they can get a 3-month supply. Very easy to do, again, if you go to kp.org/WA. We're also doing same-day delivery. Most prescriptions can be delivered to your home or office in the areas around Puget Sound and Spokane, Monday through Friday, $10 fee. And again, what a great service during this time. If patients are COVID-19 suspect or diagnosed, home delivery will be made by a physician's order as well. And again, want to bring up, we have the ability to chat. So if you have questions, please use our Care Chat feature and ask to talk with a pharmacy representative. We are happy to help you get the medications that you need. One question that has been coming up is around people stockpiling medications. It's going to be harder to do for people in our system because we prescribe and then we also dispense through our system. So if someone, for instance, wanted an albuterol inhaler for their asthma and all of a sudden I get requests for 5 of them instead of the usual 1, I'm really going to question that request, pick up the phone and find out what's going on. So the ability to stockpile, where we look at all of our resources and how we have to help everybody stay healthy. We have not had difficulty in our supply chain for medications, and it's something that we're constantly evaluating and reevaluating and planning for at the same time. So how can you help your workforce? The most important piece of advice I can give is sick people should stay home, period. Public health stay home at least 7 days from onset of symptoms and only go back to work after your symptoms have been gone for 72 hours. And that includes a fever without any ibuprofen or Tylenol. If they do show up for work, please isolate them and then send them home. Clean the area very, very well. Until more testing is available, we have to assume that all illness is COVID-19 until proven otherwise. And of course, right now, we can't prove otherwise. If there's a way for them to work from home, that of course is ideal, but we realize that's not possible for all industries. One thing we do want to make you aware of, again, is notification of possible workplace exposures. It's really important that people are notified so that they can take precautions. Kaiser Permanente does not do the exposure notification directly ourselves. The health department does that. So we can assist with return to work notes, anything that people need around that. And again, we prefer to do it via phone, video, but we are not the ones who notify the workplace around that. Leave of absence, and when people do need to get things from us, again, if possible, we are asking right now to not require a doctor's note. And we know that sometimes people are confused. So we are here to serve that role for you. And we want our clinicians doing their highest work if at all possible. But we can definitely, again, go through our questions. What are your symptoms? How long were you home? Were you isolated? What is your fever looking like? We prefer to email a note rather than have people require that written. Again, everything that we can do to reduce time and to save resources as well. Any other questions about coronavirus, COVID-19, delivery or care before I turn it over to my colleague, Todd Hess?
I did have a couple other questions for you. And going back to dispelling some myths and figuring out kind of where the truth is in some of the things that are circulating. Recently, a lot of people are advising on social media, which is fun to me because they're not doctors. Right. Saying not to avoid taking Tylenol, ibuprofen, or pain relievers with a fever, and to let the fever burn and kill the virus. What is your take on this? Where's the fact? Where's not the fact in this?
So part of that was prompted by some very early data that suggested that maybe people who were taking ibuprofen were having worse outcomes related to their infection. That has not panned out. And what we know from treating other infections and treating fever is that it does not change the course of the viral infection at all, really, but it does make you feel a whole lot better. It's awful. People are having fevers, adults, 101, 2, and 3. Those are dangerous levels. People are miserable. They will have hallucinations. They will be out of it. So we absolutely want to be suppressing those fevers. Symptomatically, people do better, but also there are some repercussions of the fever itself on the way our neurons work, the way our mind works. So please ignore that social media advice.
So talk to us about what advice you would have for someone who has a family member who's vulnerable and they need to go stay with them for a few weeks. Would maybe washing their clothes and taking a shower when they arrive? What are other steps that they might be able to take to help protect that vulnerable individual?
So the biggest one again is to maintain that physical distance, even inside a home. And so if you are out in the world because you need to be and you're coming back into a home with vulnerable people, yes, incredible awareness about what you are bringing in with you. So you don't want to actually be close to them and having respiratory droplets landing near them. So stay 6 feet away. Come in and wash your hands really, really, really thoroughly. If possible, isolate yourself in case you're an asymptomatic carrier. And we know that people do what they need to do, and that you do have to provide care, but it's really, it's that social distance of 6 feet and or a mask and really, really good hand washing, decontaminate surfaces, disinfect those surfaces, and think of things like the button you push on the microwave. Think of the doorknob that you twist to go into the bedroom or the bathroom. All of those areas should also be disinfected regularly.
I'm going to go downstairs later and clean the buttons on the microwave. I think that's
Yeah.
probably something missed in our house.
Yep. Yeah. It's those kinds of things.
Yeah. So going back to the workplace safety, can you clarify? I may have misheard. Did you say stay home for 7 days when you're symptomatic, and
Yes.
or 72 hours? Can you restate that for us?
Yes, absolutely. So people should stay home at least 7 days from onset of symptoms, and they shouldn't go to work until they've been without symptoms for 72 hours or 3 days. So
Okay.
if you're symptomatic today, Tuesday, and next Tuesday you feel like you're finally better, you shouldn't go back to work until Friday. You need 3 days of being completely better. Now, maybe it's a 48-hour thing, and this Friday, just 4 days from now, 3 days from now, you feel like, well, that was easy. I'm so glad I feel better. I don't have a fever. Then I could go back to work next Tuesday because it's at least 7 days from the first day, and I've been without symptoms for 72 full hours. Was that clarifying?
Yes, that was very helpful. Thank you.
Okay. Other questions? And we have some time at the end, so I will transition over to Todd.
Thanks, Dr. Friesen, appreciate it. As you've heard from Dr. Friesen, the health of our members, our patients, our employees, and our communities, that all still remains a top priority for Kaiser Permanente Washington. Communicating and connecting members and our communities with meaningful information really is key. And I think particularly as we heard from a social media perspective, we are not always provided with the most accurate information. So additionally, accurate and updated information is imperative. And this is why Kaiser Permanente is sharing information in a variety of different ways, including the webinar that we're doing today for the Seattle Chamber. We are also doing a number of other webinars where Kaiser Permanente is either sponsoring, co-sponsoring, or simply supporting. We are providing community informational seminars out in the community on a variety of different topics. And then also kp.org//WA is also updated regularly with the latest information. So if you want to move to the next slide, perfect. And if you haven't been out to see this, I would highly encourage folks. This is a really great place to receive information for Kaiser Permanente to provide information. By clicking on the dark blue banner at the top of the kp.org/WA, or by clicking on the orange icon that you would see over on the right-hand side, you'll be provided with all kinds of relative or relevant COVID-19 information. Information that includes, if you think you've been exposed, what to do, guidance for high-risk individuals, and then there's also subjects such as emotional well-being and support, particularly as we're working in isolation and working from home. So I would highly encourage folks, members and non-members, employer groups that are currently covered by Kaiser Permanente and not covered by Kaiser Permanente, to use this as a resource. As you heard Dr. Friesen share, we are constantly updating with additional information, and you can really look at this as a sort of a trusted advisor for the latest information. So I will turn it back over now to Sari to answer any additional questions that you might have.
Great. Well, thank you both for your time. We really appreciate it. You know, I've said this a few times, but I love hearing directly from the experts and to be able to dispel some of the myths that are out there as we're all trying to navigate through all of this information. There was one additional question that came in for Dr. Friesen or Todd. So how should an employer notify coworkers if an employee tests positive? What are some of the best practices around who should be notified from a medical standpoint?
So I don't know the official answer to that question. And I think that, quite honestly, the Department of Health will have specific guidelines about what that looks like and who needs to be notified, what kind of proximity those people have. Maintaining privacy is important. A lot of people are open about, and some don't want to have that disclosed. But certainly, just from a common sense perspective, anybody who works in the same office, in the same shared space, such as a kitchen, anybody else who would go into that kitchen, even if it wasn't the same time, or break room kind of thing, would need to be notified. But there are actual criteria and recommendations, and then things that actually have to be done and reported back to the Department of Health around that. And Todd, I think that we can probably look into that a little bit more and send that after this webinar.
Absolutely,
Great, that would
be happy
terrific.
to.
Great. One other question. So there was a headline in the Seattle Times today that the numbers are down with people contracting the virus, and hospitalization is down a bit, 20%. Is this your experience within the KP medical system as well?
So far it is, and it's really too soon to know whether this is good news or just a bump in the data. So overall, that is the trend, and things are still incredibly challenging right now.
Well, again, thank you both for your time. I will just remind everyone on the webinar that we will provide these slides and this recording on the Seattle Chamber website on the events page. So you can visit www.seattlechamber.com and find all of this information if you want to revisit any of the questions or any of the content that was shared. Thank you very much for tuning in to this webinar. We also will have another webinar on Thursday that will be focused on lending, loans, and we will also be looking at some of the payroll protection program and other emergency relief loans from the Small Business Administration. If you haven't had a chance to register, you can do that on the Seattle Chamber website. Thank you all and have a great day.
Thank you so much. Really a pleasure and honor to be with you today.
Thank you.